Do you log someone out? Oh. Thanks. Hey everyone. I am Brittany White, and this is Emily Goodwin, and we are your pharmacy staff. Welcome. So yeah, welcome. I am a dedicated clinical pharmacist to the internal medicine group, as is Emily. I split my time working with your group about 50% of the time, and from the main pharmacy department with other clinical duties and some quality improvement stuff the other half of the time. So what that basically looks like is Emily and I will show up to round with you and see your patients with you in the morning when you're on medicine service, and then we run away at lunchtime and just tiger text you for the rest of the day. And so we're just basically a resource for you for all things related to medications, and that's not necessarily just limited to when you're like with us on service. Tiger text is amazing, and we respond to it very quickly. And I just wanted to run through a few things with you, sort of like a crash course. I think if you've already done your online education modules, most of this was probably already on there, but I'm going to provide it to you with a running commentary. Let's see. Okay. So how many of you came from facilities where you got experience rounding with a clinical pharmacist? Most of you. Okay, good. Awesome. So here we have an adult inpatient pharmacy that's on the ground floor. We also have a pediatric inpatient pharmacy, and both of those are open 24/7. There's also an outpatient pharmacy called CVS Specialty Pharmacy that's on the ground floor next to the information desk. We are not affiliated with them, but we can help answer questions sometimes about medication-related issues at discharge and things like that. But we work out of the inpatient pharmacy. The number to the main pharmacy, which you will probably use a lot during your time here, is extension 7238. So outside of the hours of like 7 to 3 or 4 p.m., if you can, that's when you probably can't get a hold of Emily or myself. And you can call that number and get access to a pharmacist with any questions. We offer a lot of different pharmacist-led services here, and those are primarily antibiotic dosing. So when you're starting vancomycin or aminoglycosides, those are automatically dosed by clinical pharmacy staff here. So you would just basically order the drug, and it will automatically kick over to notify pharmacists that those drugs are needed, and we will dose those for you. We also have an anticoagulation service, so that's an optional consult service. If you want to dose your own warfarin or anticoagulation, go for it. If you don't want to do that, you can consult pharmacy for assistance, and that's primarily with warfarin dosing, but we help with a variety of other parenteral anticoagulation management. And then we also dose all the parenteral nutrition in the hospital. So we have a sort of a collaborative consult service with nutrition, and so our dietitians manage all the enteral nutrition, and we would manage dosing all of your TPN or total parenteral nutrition. And we do a myriad of other things. A lot of times you may come in and see that some of your medication doses have changed in patients with renal insufficiency, but you didn't make that change. It may be a hospital protocol, and you'll learn what drugs are automatically adjusted in this facility as you go on. But things like antibiotics, our low molecular weight here, low molecular weight heparin is Lovenox or enoxaparin. Basic things like histamine 2 receptor antagonists, we're going to automatically adjust those doses for the appropriateness of your patient's renal function. We'll change things from IV to oral when patients are able to eat. And we can do things like automatically stop stress ulcer prophylaxis for patients coming out of the ICU who don't have an indication. So these are just some of the things that your pharmacists are looking at and changing by default. These are the names of some of the pharmacy staff members that you'll encounter on rotation. Whether you're in the MICU or in the emergency room, if you're on ID rotation or cardiology, we have a pretty strong clinical pharmacy staff that you can expect to be with you, be present on rounds, and to help participate in developing medication plans for your patients. As far as our service goes on medicine, Emily and I participate in bedside rounds Monday through Friday. We're typically off on the weekends. And when you divide up into teams, you'll see right now I'll be covering Team A. So if you're on Team A, I'll be the pharmacist that you can text. Emily usually covers Team B. And then if you're on Team C, we just kind of tag team because there's only 2 pharmacists for 3 teams right now. So we're doing our best. But basically what we're doing is we're reviewing all your med lists, we're providing you recommendations, you know, hopefully catching some of those big mistakes before they happen in the first couple of days. I'm just kidding. And we're doing medication reconciliation, we'll help dosing some of those consult drugs I mentioned. So if it's anything medication related with your patient, we're there to scrutinize that and help you come up with a plan and just guide you along the way. So you can always Tiger text either of us. If you don't have Tiger text on your cell phone, you know, as of Wednesday, go ahead and download that on your cell phone because we'll be trying to contact you that way. When you order antibiotics, this is just a rundown of how we dose vancomycin and aminoglycosides in the hospital. This is in your all your online educational learnings for Erlanger, and I won't go through this, but if you ever wonder why or how we do what we do with drug levels, you can revisit that. Some things that you might see or be caught off guard by in the future are antibiotic changes. We have a very progressive antimicrobial stewardship team here that's made up of Dr. James Sizemore and pharmacist Kyle White. And they actually, outside of their consult work, they'll review antibiotic orders on every patient in the hospital, and they provide stewardship notes to give you recommendations if things need to be changed or discontinued. And so sometimes you might see things that are automatically stopped, and that'll be based off of hospital-approved policies, like if a patient has community-acquired pneumonia or unequivocal diagnosis of UTI, things that where it's not really gray and there are defined durations of therapy, our stewardship team may go ahead and place orders for stop dates or discontinue antibiotics when that's appropriate, and that's done by Dr. Sizemore. And that's how they do what they do. Kyle would like for me to read you all of this, but I'll spare you.
I'll put a note on that. They're really accessible also, so if you have a reason in your head, it's likely if you were clear about that from the start. So come to Kyle or come to Dr. Sizemore and talk through this. It's usually a learning experience, and I still do this as an opposite side. So if you're unclear or you had a rationale for why you can't longer course or different points, talk to them. There are situations where they're not seeing that patient in person. So you can defend your decision, you know, within your right and the practicing position to adjust it back. But I would say 99.5% of the time, they have really solid reasons for
Yeah.
your conditions they're making. So if anything that doesn't make sense to you, why it's being changed, ask.
Yeah, or just directly Tiger text Kyle White. He is so amenable and ready to give feedback, and usually is reviewing a lot of those patients as in-depth as they can, but you can imagine how many patients they have to review on a daily basis, and so they're really good about even if you're uncertain and you're trying to think about a drug with the best antimicrobial spectrum, you know, sometimes you can even text Kyle, the pharmacist, things like that, and it's not even a full consult, but maybe you just needed somebody to confirm what you were thinking. They're really helpful for that too. Yeah. You probably will forget how to order a TPN by the time you order a TPN, so there's not a lot of purpose in me letting you know this, but basically there are very few indications for IV nutrition. Obviously, enteral nutrition is always preferred if you have gut access and you can't feed a patient by mouth. But in the case that you do need to order IV nutrition, it's just like vancomycin or an aminoglycoside or warfarin. Usually if you type in the term TPN or vancomycin, it's going to populate with pharmacy to dose. So TPN is one of those things that automatically a pharmacist has to oversee and manage, so that's how you would order it. But if you order any of these things after 2 p.m., like a TPN, it won't start until the following day because our clinical service cutoff times are 2 p.m. So urgent things like antibiotics and anticoagulation, somebody will deal with those after the hours of 2 p.m., but not TPN. You would have to wait until the following morning. So if you think your patient could need IV nutrition, and again, that should be few and far between, but that needs to be done early in the day. Told you a little bit about the anticoagulation service. We do a lot of that with you guys side by side. You don't have to consult for anticoagulation service, but if you have a complex situation, they can do things like not only dose your antibiotics, but give you drug information about selection of the most appropriate anticoagulant for your patient, or management of, say, a difficult patient with a heparin allergy, or assistance with heparin-induced thrombocytopenia and things like that. You will love and hate the CVS outpatient pharmacy because they are definitely a resource for our patients who need access to pretty expensive drugs. So for example, patients who don't have insurance, they can get discounted insulins from our outpatient pharmacy downstairs. They can get discounted anticoagulants like the DOACs. But it's quite a process. You'll learn from one of your seniors like what is the correct process to prescribe a patient a medication down to the CVS pharmacy. And a lot of times you're doing that because they need access to one of these reduced cost drugs. And so we have this 340B contract. Essentially what that means is because our hospital has such a large proportion of indigent patients that we get special assistance on certain medications that can have reduced prices. So I'm not going to go through a laundry list of what those are, but there's basically you have to arrange those through the case manager. You can e-scribe your medication prescriptions to that CVS, and once things die down with COVID rules and distancing and things like that, they'll actually deliver the medications to the patient's bedside for you. Emily and I will let you know when that becomes a thing again, but for right now, they're not offering that service. Yeah, and to another point, financial barriers are a huge problem with a lot of our patient population. A lot of things that Emily and I are doing when you guys are developing your therapy plans is, the guidelines may say one thing, but what we have on formulary may be different. So if you're typing in the name of a drug you're trying to order and you can't find it in Epic, it may be because we have a different formulary alternative, and you can always text me or Emily to find out what that may be. Or we may look at your med list and say, I would totally agree with you if that patient had insurance. And then your follow-up question will be like, okay, well, what next then? What do you suggest? So we can help with a lot of that too for a lot of our patients who don't have any means to obtain these medications financially. There are some order sets that are going to require, like you can't order the medication one-off without going through a whole order panel. The most obvious one and one that irks the most people is the insulin order set, and this is for safety reasons, but if you're ordering subcutaneous insulin, if you're ordering an insulin drip, you have to use an insulin order set. DKA has its own separate order set from just a standard insulin drip. Those are things you should probably be aware of from the get-go. Heparin infusions, argatroban, albumin. That's another one that people tend to forget, is that whenever you're ordering albumin for a patient, these order sets are designed to make the provider think through like what they want, what the indication is, what dose you really want, because they're either high-risk medications or very high-cost medications. So make sure when you're filling out these order sets, you're being tedious about what buttons you're clicking and thinking about what you're really ordering and if that's what you intended. Usually a pharmacist will call you if something doesn't seem right, but some of these things have panels because they're associated with either bad outcomes or cost the hospital way too much money. Things that you have to get a specialist to order because they require a sign-off are some antibiotics. So if it's an antibiotic you have never seen prescribed before or seems really new or you have no idea what it does, you probably need to get in touch with Dr. Sizemore to order it. And your seniors will help you determine those. But things like fidaxomicin, you know, they may be in the guidelines, but maybe there's a particular reason why they're not our preferred formulary agent. Entresto is one of those. If you want to start Entresto, that's fine if you're on cardiology service, but if the patient doesn't already take that at home and you're trying to start it on a medicine service, they're going to ask that that order come from a cardiologist, for example. Let's see here. We talked about sort of therapeutic drug substitutions. Again, you're going to order some things that are not on our hospital's formulary that will get automatically substituted to something else. For example, we don't have Zantac. We have famotidine. We don't have Nexium. We have Protonix. Carbapenems, basically your option is meropenem. We have Lovenox instead of dalteparin. And some other pretty minor things, but usually when you order a medication, if we don't have it on this formulary, it will usually offer you an alternative to select, so you'll come across that a lot. Again, text Emily or myself if you have questions. Okay, and then common questions that you may have during order entry. These are the kind of questions that I'm hoping to field for you guys this week. I want to order this medication. How long does it take to get to the patient? You should know the difference between a routine frequency or stat. You shouldn't be ordering anything stat unless it is like dire, because stat means like the nurse has to get it within like 30 minutes and the pharmacy has to get it to the nurse within that 30 minutes and inside the patient. So if they have heartburn and they need a Protonix, like don't put it stat because you want them to get it fast. You would use like once. Usually once a medication is ordered, that has to be given to the patient within an hour of the time that the order is verified by the pharmacy staff. So keep that in mind. We don't want to overwhelm our nurses with now orders at shift change if that drug can honestly wait until, you know, an hour or two from now or this evening. So when you're placing medication orders, think about, you know, don't just right drug, right dose, right frequency. Sure, verify. Look at the warnings. Look at the time that it's scheduled to be given. If you're ordering a blood pressure medication, you need to think, do I want it to start tonight or do I need an extra dose right now? Because when you order a medication, if you order it daily, for example, our daily hospital time is 8 a.m. A BID time is 8 a.m. and 8 p.m. So if you order that carvedilol at 6:30 in the morning, it will default to be given at 8. But if you order that carvedilol at 9:30 in the morning, it may not be given until 8 p.m. when you really wanted it now. So little things, just pay attention during order entry. And that kind of answers the question. It's like, I ordered this medication yesterday. Why was it scheduled to start the next day? That happens a lot to interns because you guys aren't as familiar with like our built-in medication administration times. So make sure you're paying extra close attention to like what time it says it's actually going to be given to the patient. Hey.
So if we actually order a drug at 9:30, then do we put stat for it to be given now or once?
Just once. And a word to the wise, let's say your patient already got, you know, 3.125 milligrams of Coreg, and you're like, but I want to get an increased dose today. If you're ordering a drug that's sort of like a repeat dose of something that was already given this morning, like you're increasing the dose of something and you want that extra dose, there is a comment field that says admin instructions, and you have an opportunity to type in a little one-liner to your nurse that can explain why you've made this change that may confuse them. So for example, the most common thing that happens in this case is your patient's hyperglycemic and you wanted to order a little extra Levemir today. But the next administration time, like you've already seen the patient on rounds, it kicks out to tonight at 8 p.m. So you just order it once. 5 units Levemir once. Nurse doesn't give it. Reason, duplicate order. You should put in your admin comments, explain to the nurse why you ordered this duplicate medication. Does that make sense? So I would say, you know, I don't want to slow down your order process so it's taking you an hour to put in orders in the morning, but think about, you know, what's on the other end of that order, right? Does this make sense? Could it be confusing to the nurse or the pharmacy? If it, you know, a lot of times our resident physicians in the beginning are putting in orders, but it's not doing what you want it to do. The frequency isn't really what you want. The time is, so you put in a note to the pharmacy. If you can't figure out how to put in an order to the point that you're having to type in a text in there to the pharmacy of what you really wanted, you need to call me or Emily, because chances are that's not going to be put in right. Those notes are really hard to see, and I'd rather you learn how to do it right on the front end. Yeah. Yeah.
So back to this example, if you had a twice daily med, you found out, you decided at 9:30 you wanted lunch to be given immediately, you actually create 2 separate orders.
Exactly. And I'll show you an example of this before I leave because we've got like plenty of time. So I'm going to show you the things that get messed up the most just so you can see like what it looks like on our end. Some of this stuff is going to happen. Yeah. 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 Yes. Yeah, same thing for like hold parameters. If you order any blood pressure medication, it's going to put in like hold parameters for the nurse. Well, if you're on a cardiac rotation, you may want that beta blocker to be given for like hold for systolic less than 90, not 100 maybe. So you need to pay attention to things that are in the admin comments. You know, in the beginning, it's going to seem really tedious until you really know like what our hospital standards are. So just pay very close attention to the ordering process. Insulin doses, like how do you order insulin if you just want to order a one-time dose of Levemir? You have to go through the order panel, and that's going to seem really annoying to you at first. Let me give you a special tip. If you use an order set like every day, like insulin, you can do one of 2 things. You can open up an order set and hit something that clears out all the fields. I don't recommend that because early on some of those things are pre-populated for you in order to reduce errors. But another thing you can do is you can save your own version of an order set so that it's pre-populated with things that you most commonly, the way you most commonly use it. And that's what we advise providers to do, especially with the insulin order set, because there are other things built into an order set. It's not just meds. It'll have nursing instructions and labs, and so if you don't want to have to click through every single thing on this long order set, you can save it so that maybe labs aren't always pre-selected every time, for example. Questions. How much is this medication going to cost my patient? What kind of drug insurance do they have? On their main summary page, you can see if they have medical insurance. So pay attention, right? If it says self-pay in the corner, like under their name, that patient doesn't have any medical insurance. They may not have drug insurance. But in terms of like medication costs, if you're trying to tee up a patient for discharge and you're like, well, I don't know what COPD inhaler to send them on. How do I find that out? Because that matters. Me and Emily often don't know, but we are very familiar with things that tend to be affordable in this region or alternatives that you could use to make sure that your patient is actually able to pick up their drugs when they leave, and that's very important transitions of care. Question, why isn't there an order set for this? If you come across something that you prescribe all the time, or maybe you had a hard learning point and you ordered something and it was done the wrong way, and you're like, man, if there was just like an order set, I probably wouldn't have messed it up. Let us know. Emily and I are working on quality improvement projects constantly. A great example of this was cortisol stim tests were always being done wrong, right? You got to get the level, order the drug, get another level, but it has to be just this much time since the dose is given. And one of our residents a few years back was like, did you know since you got Epic, there's no order set for this? And it takes me like 20 minutes to order a stim test. And so we made an order set. And so IV iron is example. So we're always open to ideas for improvements if you have them. And then the last thing I want to point out is you're searching for a medication and you can't find it and you're super frustrated. You need to understand, and this is the part that I want to show you, the difference between the facility list and the preference list. How many of you are Epic savvy? Oh, Lord. Okay. We've got 5 more minutes left in this presentation. I just want to show you guys a few things. Well, it won't be an Epic problem for long. Emily and Brittany to save the day. Oh, gosh. You will know everything. I love Shansing. Okay. All right, this is sort of HIPAA, but like you guys are inducted into the process, so. Okay. And it's our service, so. All right. So I just wanted to like show you a couple of things for when you're entering orders. All right, let's say you just read a ton about SGLT2 inhibitors, and you're like, yes, these reduce cardiovascular mortality. My patient needs one. What's the one we have? What's the one we don't have, Emily? Okay. All right, you wanted dapagliflozin, and you're like, all right, I bet I probably spelled it wrong. I just graduated medical school, so I'm going to spell out the whole thing. Crap, are you kidding me? We don't have this? If you hit preference list, okay, so preference list and facility list. Facility list is going to be anything that we have in our facility. We also have access to a database. Oh, look at that, spelled wrong. Y'all didn't tell me. Okay, so this is what is out there in the world, but we don't have it on our facility list or our preference list. So facility list is what you want to stick with. But we do have Jardiance. So sometimes you may not have one thing, but we have its formulary cousin, right? Let's say your patient comes in on atenolol and you want to restart it. So you look at it, it's on the facility list, sweet. What the heck? So it's going to tell you like, hey, we don't have this on formulary. You need to choose an alternative. And most of the time, it'll give you sort of like a nice conversion. So that's a helpful tool. Insulin. All right. You will often type in the name of a drug that you want and find that it has multiple order sets. So these are all the panels that you can order insulin through. So if you're not sure which one to use, ask your senior or ask your pharmacist. For this one, for example, here's subcutaneous. Here's an insulin drip. Interesting that DKA doesn't pop up on here. So anyway, let's look at insulin. This is what I was telling you is confusing. So on this insulin order set, for example, you have all these nursing orders, labs, medications, hypoglycemia protocol. Okay, so you can actually design this built to your specifications. You can do this for any order set so that maybe when you open it, all of this stuff is unchecked. Now remember, when you modify an order set, these things are often built here to remind you to order something that the hospital has deemed necessary. Thus, it is auto-selected for you. So you have to remember not to just blow through order sets. Every time you put in an order from a panel, look at what's automatically selected for you. For example, if you're ordering Levemir today, but you already ordered it yesterday, you use this panel, all of this hypoglycemia protocol is going to blow in on the patient's profile. But now you opened it up on Tuesday, and you are going to select some Levemir. Well, guess what else is going to be on the profile? Using these frequently, it will take you less and less time. But I think that's probably some of the most common things that cause trip-ups with our interns. And anything else I'm forgetting, Yarly, that I could like show them in here?
I mean, when you were showing the thing with the duplicate orders, also remember it pops up with a little number saying how many times that's been ordered. Sometimes, like you said, when you put this order multiple times, people won't pull it off. So you'll see it where it pops up and it says, oh, you know, E50, and it'll have a little 3 next to it. There you have 2 orders from here at E50.
Right.
Not only do you want to not have a third one, you want to take away one of those extra ones. So you think that there's
Yeah. And a lot of these things, so as you guys come on service with me and Emily, just bear with us. Part of our job is like cleanup. Sometimes we're just like the trash recycling crew coming after you on the weekend to say, hey, these orders, we don't need these, you know, this could be timed differently. So we're really just here to like, we're the bumpers in the bowling alley, okay, and just keeping you in the lane. So just take everything like with a little grain of salt and appreciation, and we'll hopefully, you know, streamline things for you so that you're ahead of the curve, you know, 6 months from now in terms of like med orders and things like that. So you probably will start getting texts from one of us. And we are so excited to work with you. I think working with the medical residents is July is awesome, also exhausting, but I want you to use us as like an everyday tool and get to know us and, you know, develop relationships with each other. And I think like this is, you know, one of the best parts of our job. Anything else you want to say? Oh, yeah. Emily and I are trying a new process out where we are stationed on the 3,000 unit, which has become a project for cohorting our medicine patients, our floor patients. So on Monday through Friday, between the hours of 8 to 1:30 or 2, we will be on the floor. So you don't have to text us in some room down in the basement pharmacy. You can just pop over to the dictation room and, you know, bring us your questions. Yeah. Oh, yeah. I didn't know how in-depth I was allowed to go, Yarla. Okay. Oh, you guys are going to be here till 5 o'clock. Okay. So let's pick the same lady. Okay. Everybody's Epic should kind of be set up the same basic way. When you look at medication orders, there are like 3 different ways you can do it. So what's the best way? Depends on what you're looking at it for. The place I like to start out, just to see what my active orders are, is orders. So it tells you scheduled at the top, continuous things, so like fluids or drips, anything that's ordered PRN and can potentially be given. But you can also see your diet orders, oxygen, imaging, scheduled labs. Maybe you want to clean up the labs because they don't need a BMP every day. That's here. And other things. But when it comes to medications, at the top here, you can see what's actively scheduled to be ordered. You can put things on hold, so for a specified amount of time, that medication won't be given. You can just discontinue it. If you wanted to change this from 2 times a day budesonide to 3, although I don't recommend that, you can change the frequency. See, it's not even a button, because you shouldn't do that. Okay. So that's that. So that just tells you what's an active order that can be given. But where I like to go to see if things have actually been given is, here we go. So I went to Summary, Meds History. Look at this. So there's the documentation of what was given and what wasn't. So if you're making decisions about whether you want to change someone's blood pressure medication or their pain regimen, you should probably look here first and see, was the drug actually given? Green is go. That was given. Do you see this C here? The nurse can make a comment. I don't know what that comment of do means, but like on this pink one, it was held. Look here, per Dr. Tudor until after MRI results. Okay, and if it's red, there you go, not given. Patient off unit, no transport log given. So again, it'll be outlined into scheduled meds at the top. You can see this, okay, D5 and LR was started yesterday at 16:54. It's running at 50 mils an hour. But you know what's curious to me is it's now, that was yesterday, there's not been any documentation from the nurse this shift, so I wonder if those are still running. I'd probably just go to bedside and check it out. PRNs, okay, you know, if they said they're having a lot of pain and we're not doing a good job of controlling it very well, okay, well let me go to their meds history and see what they're actually getting. And then, so if you order something as a stat or a once it's time is over, it's, you know, they're usually on the MAR for a few hours, or after it's been given and that order's done, it will fall into discontinued meds, okay? So if you ordered potassium chloride 40 milliequivalents once because their potassium was low, and you're like, where did it go? I swear I ordered that. It's probably down here in the medications that were already given. So once it's been acted upon or charted on by the nurse, it falls into discontinued meds, and that'll get you a lot in the beginning if you're not aware. So those are the two places I would recommend. Do y'all use somewhere a different view? Okay. There are other tools you can get, and you are going to get like really queued up by Sean Singh, I'm sure. He'll show you some of these things. But micro is a great tab. Glucose, if you want to just see sugar trends, and you know, I like to see a visual graph to help me determine like how I'm going to adjust my insulin regimen. I like this glucose tab. This is all in the summary. And if you want to know days of antibiotic therapy, you could scroll through that medication history tab and like literally count the boxes, or you could go to the antimicrobial summary tab. And this person hasn't had any, but they would show here all the doses and names of the antimicrobial agents they got, any culture data that's pending, their vitals and labs, temperature curve. I think that's really useful. So you can just show up and be like, yeah, they're on day 3 of antibiotics, and all you had to do was like count the 3 days here instead of going all the way through the med history tab. So that's kind of like a crash course, the most basic stuff, but can't wait to work with some of you guys Wednesday, and we'll show you more along the way. Okay, that's all I got. Kinda, not really. So Team A has a pharmacist. That's me, Brittany. Team B has a pharmacist. That's Emily. You should include us on your group text message with the team to let us know what time you plan to start rounds. But we will text you if we don't hear from you. So we'll show up, we'll round with you at bedside most days unless we've got meetings or something. And then Team C is what we call the orphan team. Right now Team C doesn't have a dedicated rounding pharmacist. So what that means is Emily or I will review your patient's charts from afar and maybe send you recommendations via Tiger text, or just come find you on the floor if there are things about the patient's regimen that we want to discuss with you. And that's pretty much how our rotation works for the time being. We used to try to kind of round with all teams every 2 weeks. We'd switch, and that got really confusing for the interns because like you'd show up on Team A and be like, well, I don't know, I didn't know we had a pharmacist today. And then so hopefully in doing this, we're going to be available for you on 3000. So you always know you can find one of us on the 3000 unit when you're there. You know you'll always have someone on Team A that you can talk to, someone on Team B. And if you happen to be on Team C, you can text us with all your questions because we are already reviewing your patients, but we won't have someone physically there with you on rounds to sort of see the patients with you. Okay. All right. Thank you, guys. Welcome.